Welcome. In this session, we'll be discussing posterior segment imaging in glaucoma, and we'll be discussing about optic nerve weight photography, optical coherence tomography, and optical coherence tomography angiography. Optic nerve weight photography provides us with more time to analyze the structural features of the optic nerve weight as compared to clinical examination. It allows easier detection of glaucomatous changes, and certain features such as optic disc hemorrhage and peripapillary atrophy are better detected and analyzed with optic nerve weight photography, which can be difficult to detect in clinical examination and are not detected by other imaging techniques. Optic nerve weight photography enables detection of progression also by revealing subtle changes in the optic nerve weight topography over time. Optic nerve weight photography, however, does not give quantitative information of the amount of neural loss or the rate of progression of neural loss, and there is a poor correlation between detection of progression by photography and clinical examination and by visual field examination because of a time lag between structural and functional progression. OCT enables high resolution and reproducible cross-sectional imaging as well as quantitative evaluation of the structural status of the optic nerve head, retinal nerve fiber layer and macula, which are important in the evaluation of a glaucoma patient. As we have learned in previous sessions, structural changes often precede functional loss in early glaucoma, so OCT evaluation for glaucoma may be important early on in the disease process. OCT avoids intra-observer and inter-observer variability which occurs during ONH assessment on the slit lamp and clinical photographs, and presently optical coherence tomography is more commonly used than other technologies which are available for the structural assessment of the optic nerve head and retinal nerve fiber layer, and which we will be discussing briefly later in this session. Optical coherence tomography machines contain normative data to help in diagnosis of glaucoma by detecting deviations from normal, and optical coherence tomography analysis can also help us to detect progression and assess rate of progression of glaucoma. OCT technologies available include time domain OCT, spectral domain OCT, and swept source OCT. Time domain OCT was the initial OCT technology available to assess the posterior segment but is no longer used because the more advanced versions of OCT technology, namely the spectral domain OCT and swept source OCT, allows faster acquisition of images and provide higher resolution of images. Time domain OCT is based on assessment of optical path difference between the light beam being reflected from the eye and the reference beam to determine the depth of the layer of interest in the posterior segment of the eye. And to determine this optical path difference, the reference mirror reflecting the reference beam is moved. In this photograph, we see an image of a macula on a time domain OCT. Both spectral domain OCT and swept source OCT use Fourier analysis to analyze the light being reflected from the eye. Fourier analysis decomposes the composite waveform of the light reflected from the eye into its component waves. The amplitudes of these component waves are measured to detect the reflectivity of the layer of interest. Spectral domain OCT devices use a superluminescent diode as a light source which emits a broadband wavelength centered on 850 nanometers and a spectrometer as detector of the reflected light. As we have mentioned, SDOCT allows faster scanning speed and higher resolution, and SDOCT devices can have an EDI mode or enhanced depth imaging mode in which the light source is positioned nearer to the eye being examined. So in this photograph we see an image of the macula from an SDOCT device. Swept source OCT uses a swept laser as the source of light, with the light emitted being of a continuously varying wavelength centered on the wavelength 1050 nanometer, and a diode is used to detect the light emitted from the eye. The longer wavelength of the swept source OCT allows deeper penetration, providing better resolution of the deeper structures. This photograph shows an image of macula from a swept source OCT, demonstrating the better resolution of deeper structures such as the choroid behind the retinal pigment epithelium. Adaptive optics can be combined with OCT to increase resolution of the image. Adaptive optics technology uses wavefront sensors and deformable mirrors to correct optical aberrations caused by the ocular media. Before going into the details of OCT analysis of glaucoma patients, we should note that although all the available OCT devices analyze the optic nerve with the retinal nerve fiber layer and the macula, the parameters mentioned in the reports from these devices do differ slightly from each other. And in this photograph we see the report from the serous OCT from JAIS. Retinal nerve fiber layer analysis is important in glaucoma because, as we have discussed in previous sessions, the peripapillary retinal nerve fiber layer thickness decreases in glaucoma, and the measurement of RNFL thickness with the OCT is taken along a circular scan line of radius 3.45 mm centered on the optic nerve head. And the parameters mentioned in the report of RNFL analysis include global average thickness of the RNFL along the entire circle, and in the report from the series we find it here, and the values are marked in red as shown here in this figure when the values deviate significantly from the normative data. The average RNFL thickness in each of the four quadrants, superior, inferior, nasal and temporal, are given in these circular figures for the right eye and the left eye, and the average thickness of the RNFL in each of the 12 clock hour sectors are given in these figures. The average thickness values in each of the quadrants and sectors are given numerically beside each quadrant and sector, and the quadrants and sectors are shaded in red, yellow or green according to whether the average RNFL thickness values in each of these quadrants and sectors deviate significantly from the normative data or not. There is also a line plot or TS-NIT map which is represented by this figure. TS-NIT standing for temporal, superior, nasal, inferior and again temporal sectors of the peripapillary retinal nerve fiber layer, in which the retinal nerve fiber layer thickness along this line is represented by black lines, a black continuous line for the right eye and a black dotted line for the left eye in this report. And also the zones of the normative data are shown, with the green zone representing the normal range of RNFL thickness along this circular line and the red zone representing RNFL thickness below normal values. There is a yellow zone between the green and the red zone which represents borderline thickness of the RNFL. RNFL analysis parameters which are considered to have the best diagnostic accuracy include the global average RNFL thickness and the average thickness of the RNFL in the superior and inferior quadrants. The global average RNFL thickness, which is mentioned here in this report, has been found to be the most reproducible, as it does not need to divide the RNFL into sectors and quadrants, and it is considered to be more accurate for detection of glaucoma progression as compared to diagnosing glaucoma. Average RNFL thickness in the superior and inferior quadrants, which are shown here in this report, is said to be more efficient in detecting localized RNFL defects and is considered to be more important in diagnosing glaucoma. Then we come to optic nerve head analysis, and the higher resolution imaging of the optic nerve head with the spectral domain OCT avoids interpolation of non-image locations, which was previously required with the time domain OCT, thus decreasing errors in the measurement of the optic nerve head parameters. And the quantitative optic nerve head measurements which can be taken with the OCT include optic disc area, and to measure the optic disc area, the inner margin of the Bruch's membrane is considered to be the outer margin of the optic disc. Neuroretinal rim area can also be measured by OCT, and it is mentioned here in this report. The neuroretinal rim width or thickness measured by the OCT is represented in this sectorial map, which mentions the neuroretinal rim width or thickness in the temporal, superior, nasal, inferior and again temporal quadrants. And the neuroretinal rim width or thickness is measured as the minimum rim width or MRW or BMO MRW, which measures the minimum distance from the Bruch's membrane opening to the inner margin of the neuroretinal rim along every location around the disc. And neuroretinal rim width or thickness is said to be more sensitive than other rim-based parameters for diagnosing glaucoma. And the cup disc ratio is also mentioned in the report as shown here. As with global average RNFL thickness, if any of these parameters deviate beyond normative data, that measurement is labeled in red. In addition to retinal nerve fiber layer and the optic nerve head, macula is the third parameter which is considered for glaucoma analysis with OCT. And macular OCT is considered important in glaucoma because macula contains 50% of all the retinal ganglion cells. And the composite thickness of the retinal ganglion cell layer and the retinal nerve fiber layer contribute to a significant fraction of almost 40% of the entire macular thickness. And as we have discussed in the session on visual field defects in glaucoma, damage to central visual field has been found in early glaucoma. And macular analysis has been shown to have similar efficacy as RNFL analysis in diagnosing glaucoma. The retinal layers included in thickness measurements in macular analysis of glaucoma differ across various OCT platforms. The CIPL thickness is reported in serious OCT from Zeiss, and it measures the combined thickness of the retinal ganglion cell and the inner plexiform layers as shown here in this figure. This figure shows a composite macular and RNFL analysis, and deviation from normative data is represented in this figure. This figure represents the line plot for RNFL, and this plot represents the GCIPL thickness in sectors. The RTView OCT from OptiView measures GCC or ganglion cell complex as shown here in this figure, which is the combined thickness of RNFL, retinal ganglion cell, and also the inner plexiform layer. And each retinal layer of the macula can be segmented and measured separately by the glaucoma module in the Spectralis OCT from Heidelberg. In certain situations, macular analysis is useful to diagnose and monitor progression of glaucoma, particularly in patients with myopic disc, large areas of peripapillary atrophy, and advanced glaucoma, because in advanced glaucoma, RNFL thickness represents mostly glial cells, and RNFL thickness do not decline further with glaucoma progression. And it is important to remember that in high myopia, RNFL appears thin, and there is a temporal shift of both the superotemporal and inferotemporal RNFL bundles, resulting in errors in comparative analysis of sectoral RNFL thickness with comparative data. Macular analysis in early stages of glaucoma shows arcuate areas of thinning respecting the horizontal meridian as shown here in this figure. And in advanced disease, the macular thinning becomes more diffuse. On the Spectralis OCT, in addition to color-coded maps showing the measured thickness, plots showing hemispheric asymmetry in each eye and asymmetry between the two eyes are also given. And asymmetry between the two eyes is considered to be more important than hemispheric asymmetry in glaucoma analysis. Detecting progression is considered to be the most important utility of OCT in glaucoma, and serial measurements of RNFL, ONH, and macula can detect longitudinal changes in morphological abnormalities of these structures and estimate the rate of change. However, there is no consensus as to which parameter is the best in detecting glaucoma progression. Recent studies suggest that detecting progression with serial measurements of BMO MRW of the optic nerve head may be more difficult than detecting progression with serial measurements of RNFL thickness because of changes in location of the Bruch's membrane opening with age and glaucoma progression. And progression on OCT should always be correlated with progression of visual field defects. Patients demonstrating faster rate of progression need more aggressive treatment. OCT measurements have been found to be reproducible in the short term, and a change of 5 micron in the global average thickness of RNFL is considered as indicative of progression in the short term. And this change is 10 times the annual rate of age-related decline of RNFL thickness. Even if RNFL measurement values are initially within normal limits, monitoring longitudinal decline of the RNFL thickness in glaucoma suspects can also help in early diagnosis of glaucoma. Guided progression analysis available on serous OCT, as shown here in this photograph, can estimate the rate of change of cup disc ratio, as shown here in this graph, and rate of change of RNFL thickness, average RNFL thickness, superior RNFL thickness, and inferior RNFL thickness in these three graphs. Although CT is clinically useful in detecting progression in diagnosed glaucoma patients, ability of OCT to diagnose glaucoma by distinguishing between glaucomatous and non-glaucomatous eyes is limited, and studies on glaucoma suspects have shown that individuals with RNFL defects have a higher chance of developing visual field defects in the future. As we have discussed earlier in this session, enhanced depth imaging or EDI OCT and swept source OCT allows imaging of deeper structures, thus allowing imaging of lamina cribrosa, and defects which can be detected in the lamina cribrosa include posterior displacement of lamina cribrosa, altered thickness of lamina cribrosa, and focal defects in lamina cribrosa which correlate with other structural and functional deficits in glaucoma. However, quantitative analysis of lamina cribrosa is not yet available. Artifacts which can interfere with accurate OCT analysis include poor quality scans, segmentation error in which the machine fails to accurately identify the different layers of the retina sequentially, alignment error which occurs due to improper alignment of the machine, as a result of which a part of the required scan line is not scanned, centration error which occurs when the circular RNFL scan line is not centered on the optic nerve head, and ocular comorbidities such as high myopia, in which, as we have discussed, there is a temporal displacement of the superotemporal and the inferotemporal RNFL bundles, posterior vitreous separation, following which there is thinning of the RNFL at the site of posterior vitreous attachment, because the pull of the attached posterior vitreous leads to artifactual thickening of the RNFL at the site of attachment of the posterior vitreous, and uveitis and epiretinal membrane can lead to artifactual thickening of the peripapillary retinal nerve fiber layer as well as macular ganglion cell layer. Conditions which can demonstrate RNFL thinning mimicking glaucoma include BRVO, but in BRVO there is thinning of all retinal layers and not only the RNFL in both peripapillary and or macular areas in the sector of the fundus affected by venous occlusion. Neuroophthalmic diseases can also demonstrate RNFL thinning, but in this situation, thinning of temporal and nasal quadrants are more common than thinning of superior and inferior quadrants of the retinal nerve fiber layer. Prior to the wide availability of OCT, other technologies which were available to image and quantitate the optic nerve head and the retinal nerve fiber layer were confocal scanning laser ophthalmoscopy or CSLO, which was available with the Heidelberg retina tomographer, which could image and quantitate both the optic nerve head and the retinal nerve fiber layer. Although called a retina tomographer, Heidelberg retina tomographer was specifically meant for analyzing the optic nerve head and the retinal nerve fiber layer in glaucoma. In contrast to OCT, which images the retina in cross-section, CSLO used to image the retina in planes parallel to the surface of the retina. The other technology available prior to OCT was scanning laser polarimetry, which was available with the GDX machine from Zeiss and which could image and quantitate only the retinal nerve fiber layer, and it determined RNFL thickness by measuring the change in polarization of an incident polarized light passing through the retinal nerve fiber layer. Optical coherence tomography angiography or OCTA allows blood vessel imaging by detecting the difference in OCT signal reflected from flowing blood cells in the blood vessels against the steady OCT signal detected from background retina on sequential OCT scans from the same identical location. And OCTA gives following parameters as surrogate markers of perfusion: the vessel density, which is the number of blood vessels detected in an unit area, and flow index, which is the ratio of detected flow to average flow. So in this photograph we see the OCTA images of the optic nerve head. the retinal peripapillary capillaries and the macular region in a normal patient and in a patient with glaucoma. And with OCTA, reduced capillary perfusion in both peripapillary and macular regions has been shown in glaucomatous eyes, with this reduced capillary perfusion areas corresponding to other structural and functional glaucomatous defects of these eyes. And currently, OCT analysis of RNFL, ONH and macula and OCTA analysis of RPC and macula can be done with the same OCT device. To recap the salient points, ONH photography allows more time than clinical examination to detect subtle glaucomatous changes. Serial ONH photographs enable us to detect progression of structural glaucomatous defects. But ONH photography does not provide quantitative assessment. Optical coherence tomography provides quantitative measurements of optic nerve head, retinal nerve fiber layer and macula. OCT is said to be more useful in detecting glaucoma progression than differentiating glaucomatous from non-glaucomatous eyes. RNFL thickness map is taken along a circular cross-section centered around the optic disc. Global average thickness of RNFL is more reproducible and is useful for detecting progression of glaucoma. Average thickness of RNFL in the four quadrants, particularly the superior and the inferior quadrants, can detect focal glaucomatous defects and is more useful in diagnosing glaucoma. Among ONH analysis parameters, NRR width or NRR thickness is more important than neuroretinal rim area and cup disc ratio. Macular analysis, particularly analysis of ganglion cell layer, is similar in efficacy as RNFL analysis in diagnosing and detecting progression of glaucoma, and it is particularly useful in patients with myopic disc, extensive peripapillary atrophy, and advanced glaucoma. Optical coherence tomography, angiography or OCTA can detect decreased vessel density and flow index in retinal peripapillary capillaries and macular capillaries in patients with glaucoma. Thank you for listening.